Our next speaker is Don Hopkins, and Don is now the Associate Executive Director of the Carter Center. Some of the papers that evolved out of West Africa appear under Don's authorship, and probably the most important was that Don had two areas of Sierra Leone. He didn't have enough resources to do mass vaccination in all, and he did mass vaccination in half and surveillance and containment in the other half, and was able to stop smallpox quicker. And then that really proved the surveillance containment thing. Don also is the author of several books, and for those of you interested in smallpox history, what's the correct title of the small?
Current edition is Smallpox, the Greatest Killer.
Okay.
The greatest killer of smallpox in history.
But my favorite story is when Don Hopkins wrote his book on the history of smallpox. He got a cake which was decorated with the cover of his book, and he got it up in Chicago, and he brought it down. He put it in a classroom here at CDC, and nobody was to eat this cake. It was going to be there for that. Well, Don left the room, and as he came back in the room, here is Bill Foege coming out, chewing a piece of cake, and saying that cake was great. So we welcome Don to talk about his passion for guinea worm and its eradication. Don Hopkins.
Thank you, Stan. In fact, if that had played out that way, I might not be here. But Bill Foege pulled that practical joke on Bill Watson and caused Bill to almost pass out. I want to begin here by also acknowledging that we've had several of the smallpox warriors who worked in the guinea worm eradication program, foremost among them being Andy Agel, who's not with us now, unfortunately. But Andy came over and worked for 6 years, more than 6 years, at the Carter Center. Last night there were some stories told. In my experience, Andy liked to tell two stories. The one was the story of George Lithcott at the booth with his non-existent visa coming into what was then Dahomey. The other story Andy liked to tell was of his arrival in Togo with Bernie Challenor. Bernie Challenor was the medical officer, and Bernie was very proud of the French he had just learned here at CDC. I don't speak French, but as the story was told, as Andy told the story, he said that they came into this hotel with their luggage, and Bernie marched up to the guy behind the front desk and announced very loudly in French, "Bonsoir, monsieur, I am a room." And well, guinea worm disease, this program against it is a direct heir of the smallpox eradication program. Instead of the surveillance containment strategy, we have the case containment strategy for guinea worm eradication. But this disease has been around since at least ancient Egypt, manifest by these worms coming out of people's bodies a year after they've drunk contaminated water. No vaccine, no curative treatment, but it can be prevented by teaching people to boil their water, which is generally too expensive, filter their water through a cloth. There's a chemical you can put in the water to kill the parasite there, and of course providing people with clean drinking water in the first place, and teaching them when they have worms coming out not to go back into the water and allow the parasite to continue its cycle. To cut to the chase, this is where we are, with cases now having been reduced from an estimated 3.5 million in 1986 to just over 10,000 last year. We're going to have more cases than that this year because of Sudan. Villages from over 23,000 to about 2,000. And endemic countries, 3 of these were in Asia: Yemen, India, and Pakistan. to 9 countries as of 2005. Here's another representation of where we are geographically, with the yellow countries having eliminated the disease already, those in red still being endemic, having reported more than 100 cases each last year, and those in the crosshatched, that appears to you as pink, had less than 100 cases reported last year. And this year, almost certainly, Nigeria is also going to report less than 100 cases. Niger Republic may report less than 100 cases. So far this year, Ethiopia and Cote d'Ivoire have reported only 1 case each the first 6 months of this year. Togo and Burkina are also very close, as you'll see in a minute. As of 2005, this is what was left reported. And I should point out that Ghana began more than 15 years ago with about 180,000 cases of disease. Nigeria began with over 653,000 cases of the disease. Uganda began in 1991, having counted then more than 126,000 cases of the disease. First 6 months of this year, except for Sudan, for which we only have 5 months of data, you know that the peace agreement was signed in Sudan early last year, and now we're getting into areas, particularly in the extreme southeast of Sudan, to which the program did not have access. Sudan's program actually got underway in 1995, and President Carter negotiated a ceasefire, and workers began working on both sides. And you see again here that we were hoping to pick up 2 or 3 more countries this year, report 0 cases all year, but Burkina so far is the only country that is still eligible. Last year, Burkina's, most of their cases were in June, July, and August, so we still have July and August to go to see if we will pick up 1 more country to have no cases reported for all of this calendar year. But whatever happens this year, we expect that several of these countries are going to drop out by next year. And indeed, Nigeria may have had its last case already. But just to look at 3 of these countries in a little more detail, so far Uganda is the one among the 4 highest endemic countries, the others being Sudan, Ghana, and Nigeria, that has gotten to 0 cases. And that despite a lot of insecurity up in the northeast part of the country. But they were blessed by a very strong backing by the Ministry of Health and other levels of government, and in the latter years by very creative, very tenacious national coordinator. And so that Uganda now has reported 0 cases in 2004, 2005, and so far in 2006, indigenous cases, and that despite sitting next door to Sudan and receiving imported cases from Sudan regularly. Nigeria, the big man on campus in the smallpox eradication program in West Africa, and certainly the biggest repository of guinea worm disease at the beginning of this program. Don't have time to go into a lot of detail here, but I will just say that both Nigeria and Sudan, which together were Nigeria and Ghana, which were the 2 highest endemic countries in the beginning, both stagnated for a while for similar reasons in the mid-1990s. But then former head of state that's been mentioned here before, General Gowon, who's now former head of state there, joined the guinea worm eradication program in 1998 and has been very, very strong in supporting the program there. And as I said earlier, that case in Nigeria in May this year may well have been Nigeria's last case. Ghana, which began there in 1989 with a lot of disease and got off to a very fast start. Dave Newberry was our first person there, has suffered in 1994 from an outbreak, and 1995 again, an outbreak of ethnic fighting during the peak transmission season in the highest endemic area of the country, and is still trying to recover from that. This just is one way of representing the data reported in the first 6 months of this year. The black squares indicate no indigenous cases, and as you can see, Burkina Faso has had none so far this year. Cote d'Ivoire and Ethiopia reported one indigenous case in June. One way of tracking our progress is to have above this the comparable period last year, and you can just easily see visually the increase in the black squares. Another way here, just showing the percentage change from year to year, from month to month rather, over the regular periods, different periods, of the number of cases reported, and for everybody except Sudan, which has only 5 months of data. This is 6 months worth of data, and you see Niger, the numbers are still small, but slight increase so far this year. The tri-border area of Burkina Faso, Niger, and Mali has been plagued by these so-called black Tuaregs, the nomads in that area that have been carrying guinea worm back and forth. But Burkina has cleaned up their part of that. Mali has been, which suffered from insecurity the longest among those areas, has been the one that's had the most trouble, but we think that we'll get on top of that this year. In Mali and Niger, their peak transmission season is late, September, October, November. This slide's from WHO, showing in blue the countries of the world that have been certified as not having guinea worm being transmitted, and as you see, there are several more countries in Africa to be certified, including the ones most recently endemic, but all of Asia now has been certified as free of disease, and the countries that actually had transmission during this program were Yemen, India, and Pakistan. Senegal so far is the only one of the African countries that were endemic when this program began that has been officially certified. Part of the problem being endemic countries remaining on the borders of some countries that have broken transmission. This is the final schedule. As some of you know, we started out with a target date of 1995, which partly thanks to a one-year-long incubation period we didn't make, but for many other reasons as well. But we're looking to stop transmission in these 7 countries this year or next. Ghana in this period, and Sudan at the end of 2009. Part of the strategy very early on was to leave Sudan alone until they stopped fighting, but thank God we changed that strategy. President Carter negotiated a ceasefire in 1995, and Sudan has gotten a big head start. Despite the increase in cases this year, they are far ahead of where they were before. And indeed, all of the northern states of Sudan are now and have been guinea worm free for the last 2 or 3 years. One last slide just to compare these 2 diseases, to note that neither has an animal reservoir. Both are easily diagnosed. Neither has a treatment or a cure. Both are preventable. Guinea worm with more difficulty. And one of the things we lived through for the new EIS officers from the beginning was the idea that what do you mean you're going to eradicate this disease? You don't have a vaccine. Well, we're close to it without a vaccine, and the lesson here is that you don't have a vaccine, don't have to have a vaccine in order to eradicate a disease. And yes, indeed, you can get people to change their behavior if you approach them with respect and recognize that it's their problem, it's not your problem. Your job is to help them to understand how to protect themselves. Another important lesson from this program has been, while we tend to get fixated on the technology, the jet injectors, the vaccine, the nylon cloth filters, it's the sociology that's very, very important. And that has been a key aspect of it, not just in addition to the cross-cultural thing that Jean Lescott spoke of, just the idea of understanding people and where they are. in each of the instances where this disease still remains and has not yet been eliminated, it's there for a reason, and usually that reason involves sociology. It's a particular ethnic group that's been marginalized or some other reason involving sociology, including inadequate understanding on the part of the would-be eradicators. But the biggest difference between these two diseases is in the incubation period. And I just want to note here, since we get the question very often, how soon, that the smallpox program succeeded about 22 incubation periods after December 1976 informal target date. And we've still got 11 more years to go before we would meet that. Thank you very much.